Hello, everyone. Good afternoon, and thanks for joining us today for our webinar on gold carding. I'm Ben Gonzalez with TDI's Communications Office, and today we're getting an overview of Texas House Bill 3459 and TDI's rules to implement this first of its kind prior authorization measure here in Texas. So our presenter today is Rachel Bowden. Rachel's the director of our Regulatory Initiatives Office here at TDI in the Life and Health Division. And let's get started with the presentation, and I'll see you back here for Q&A.
Good afternoon. I'm Rachel Bowden, Director of Regulatory Initiatives for TDI's Life and Health Division. Thank you for joining us for today's webinar. This presentation will walk you through the statute enacted by HB 3459 from the 87th Legislative Session and TDI's rules implementing the statute. At the end, we'll have time for your questions. In today's presentation, we'll provide an overview of pre-authorization exemptions under 3459. We'll talk about which plans the law applies to and some key definitions, eligibility for an exemption, initial grant or denial of exemption, continued eligibility or rescission of an exemption, communication methods, and independent review of rescissions. We'll have time for questions at the end. In 2021, the 87th Legislature enacted House Bill 3459. That bill added Subchapter N to Insurance Code Chapter 4201. And the bill really provides an exemption from pre-authorization requirements for physicians and providers providing certain healthcare services, subject to the criteria that we'll discuss in more depth. The law applies to TDI regulated health plans offered by HMOs, PPOs, and EPOs. But the law does not apply to the Medicaid or CHIP programs. The primary requirement of the bill was to require issuers to exempt a provider from a pre-authorization requirement for a particular healthcare service if that provider has a 90% approval rate when looking at their history of pre-authorization requests for that particular healthcare service. So the purpose is, if a provider is always meeting the requirements, they shouldn't have to keep jumping through these administrative hoops, and maybe even pre-authorization isn't important if they're always approving it. So that's, I think, kind of the theory of the law, and recognizing that pre-authorization does serve an important role when providers are less consistent in their performance, but that 90% approval rate provides some assurance that the exempt providers have really demonstrated an understanding of medical necessity and practice appropriately. There is no requirement for providers to request an exemption. They are eligible without taking any action, and it's the issuer's obligation to notify them when they qualify or when they've been evaluated and do not qualify. So to talk about some of the key definitions, a lot of the content of the rules is embedded within these definitions. So it's an important section of the rules that I really encourage you all to take a look at. So that's in section 19.1730 of Title 28 of the Texas Administrative Code. Some of the definitions are actually established by statute with reference to 843.002. So the definition of healthcare services, for example, is one that's defined in 843. That definition is very broad. Consistent with other rules, TDI has interpreted that definition broadly to include all types of services, including prescription drugs. Likewise, physician and provider are broad terms. So we didn't identify any, particular physicians or providers that are not potentially eligible for an exemption based on those definitions. Particular healthcare services is a term defined in the rules. So it, incorporates the definition of healthcare services in the statute and explains that the granularity with which a service is eligible for an exemption as a kind of particular healthcare service, that granularity is based really on which healthcare services are subject to pre-authorization. And under SB 1742 from the 86th legislative session, health plans are already required to post pre-authorization requirements on their websites. And so we think that the way the rule is structured is to require that the exemptions be based on that same listing. So if you have a listing for every healthcare service that a provider performs that is subject to pre-authorization, they could be receiving an exemption for that service based on their kind of data reflecting their historical pre-authorization requests. A pre-authorization exemption, is a privilege that allows a provider to not have to request pre-authorization. So it's kind of assumed that they've received approval for that service. And it's for care that's rendered or ordered by a treating physician or provider. So, some care a treating physician both orders and provides. But for other care, a surgeon, for example, might order an imaging test. And so they are not the one providing that imaging test, but they're the one that assesses the medical necessity for it. So they're the ones that have historically been requesting pre-authorization. And if they're doing so appropriately, and they have a history, that gives them that 90% approval rate, they will receive an exemption from needing to ask for pre-authorization in future. So that's, I think, an important part of the rules to understand. We do have a definition of treating physician or provider that explains, the exemption is only applicable for the exempt provider's patients. That exemption can't be extended to care being provided by, other providers, except where appropriate. And again, to talk about when is a exemption rescinded, it's rescinded based on an adverse determination regarding a pre-authorization exemption. And that occurs when one or more claims is retrospectively reviewed and the issuer determines that, based on that review, it did not meet the issuer's screening criteria. And if it causes, the percent approval rate to go below 90% and causes the issuer to rescind a pre-authorization exemption, that then becomes an adverse determination regarding a pre-authorization exemption, which is eligible for an independent review. So exemptions eligibility is based on the physician's or provider's approval rate. So that initial assessment is based on all eligible pre-authorization requests for a particular healthcare service. To be an eligible pre-authorization request, the request must be submitted and finalized during the most recent 6-month evaluation period. So it can't be pending appeal. So, for the initial evaluation period, that's between January 1 and June 30th of 2022. So it's looking at all of those pre-authorization requests for that service that were submitted during that time frame that are not pending appeal and that result in the issuer either approving that service or giving an adverse determination for that service. So sometimes requests are modified, and so for whatever reason, maybe the issuer says, hey, you requested this, but we think this is more appropriate. If the provider modifies their pre-authorization request, then the data is really based on that updated service request. And that updated service will either be approved or denied. So that's kind of the basis for the data that's informing these evaluations for an exemption. Sometimes a pre-authorization request might include a few different services that are subject to pre-authorization. But the outcome for each service is counted individually. So if I included 2 different imaging procedures and one was approved and one was denied, the denial doesn't affect the approval. Each one is counted individually when assessing the eligibility for the exemption for that particular healthcare service. So treating providers, again, that's an important definition within the rules. Providers are identified using their National Provider Identifier, or NPI number. So that number is used when they submit the pre-authorization requests, And so the data for evaluating the pre-authorization requests are tied back to that NPI number, and the exemptions are granted by associating the submitting provider with their NPI number. Exemptions apply to care ordered, referred, or provided by the treating provider. So again, if a provider is the one prescribing a particular drug, they're not providing the drug, maybe the pharmacy is, but they're the one submitting the pre-authorization request, and they're the ones that get the exemption for that drug for when they, if they have that 90% approval rate. So generally, exemptions are occur at the individual provider level, but there are cases when other providers, like a nurse or a physician assistant, is appropriately practicing under a physician. They might be submitting pre-authorization requests under that physician's NPI number, and they can rely on that an exemption when it applies as appropriate. In contrast, say a physician has a group that they practice with, and some of the physicians have exemptions and others do not. Those partner physicians can't rely on their partner's exemption, because the exemption only applies to the care provided to the patients of the treating provider. So that exemption can't apply to the patients of your partner, because you're not the treating provider for those patients. So your partner physicians need to continue requesting pre-authorization until they qualify for their own exemption. So in the example where the care is ordered by an exempt provider, but treated, and the care is actually provided by a different provider, like the case of an imaging test, the person billing for that imaging test needs to include the ordering provider's name and NPI number. Without that information on the claim, there's no way for the issuer to know that a pre-authorization exemption is applicable to the claim, and it could be denied based on lack of pre-authorization or paid at a reduced rate according to the terms of the contracts. Initial evaluation. The initial evaluation period ran from January 1 through June 30th of 2022. Following an evaluation, notice must be provided indicating that the exemption was granted or denied within 5 days of completing the evaluation. The deadline for the initial evaluation notice is October 1, 2022. For subsequent evaluation periods, the deadline for the notice will be 2 months after the evaluation period. The evaluation to grant an exemption must be based on at least 5 eligible pre-authorization requests. If there are fewer than 5 eligible requests, no notice is required. Before rescinding an exemption, the exemption must be in place for at least 6 months. That means the first date an exemption can be rescinded will be June 1st of 2023. Here's an example. So the initial evaluation period ran from January through June. The initial notice of denial in this example is issued by October 1st. So the next evaluation period starts just where the last one picked up, starting July 1st and ending December 31st of this year. 2 months following would be March 1st for the deadline for that notice of whether that evaluation results in an exemption or a denial of the exemption. And we'll do another example showing an evaluation that's approved. When denying an exemption, the denial notice must include the date for the relevant evaluation period, information about the failure to meet the criteria for an exemption. For example, an exemption would require a 90% approval rate. So it should explain, well, what was the approval rate of something, less than 90%. The notice must include information about how to appeal the denial with the issuer, and that appeal happens through the issuer's normal complaints and appeals processes. And the notice should also include information about how to file a complaint with TDI. And I've provided an example that provides TDI's contact information for filing complaints. And that's the same contact information used in health insurance policies. So here's an example for when the initial evaluation is granted. Again, the evaluation period was from January 1st through June 30th of 2022. The notice was issued by October 1. And since the exemption is in place, an issuer can continue that exemption, but if they want to rescind it, they have to wait at least 6 months. And it would be subject to rescission starting June 2023, January 2024, or a future date in January or June. When granting an exemption, the notice must include a plain language explanation of the effect of the exemption. It must also explain the health care services and health benefit plans to which the exemption applies, as well as the duration of the exemption. Finally, the notice should include claim coding guidance to help issuers or help providers understand what information is needed when a different provider is providing the service. If a provider continues to submit pre-authorization requests for a healthcare service that is exempt, the issuers must provide a notice as required by the statute. Continued eligibility. Issuers may continue an exemption without another evaluation. While an exemption is in effect, the issuer cannot deny payment based on medical necessity except for material misrepresentation or failure to perform the service. They may conduct retrospective reviews only to determine continued eligibility for an exemption or to investigate a basis for denial. An exemption must last at least 6 months before it may be rescinded. Retrospective reviews. Issuers may randomly select up to 20 claims to retrospectively review to evaluate continued eligibility for an exemption. The random sample must include at least 5 claims. So if there are fewer than 5 claims, the exemption cannot be retrospectively reviewed or rescinded. Medical record requests must be made either during an evaluation period or within 90 days of the evaluation period ending. And when requesting medical records, issuers must provide at least 30 days for the providers to give them the records. Physicians and providers are obligated to maintain those medical records and provide them upon request. If records aren't provided, the issuer may decide that the claim wouldn't have met the screening criteria, and that could lead to a rescission of an exemption. Rescissions. Again, issuers may rescind an exemption only after they select a random sample of at least 5 and no more than 20 claims to review. And a rescission occurs if they determine that fewer than 90% of those claims met the criteria. And that's based on a review by a Texas licensed physician of the same or similar specialty. They must provide at least 30 days notice before a rescission is effective, and the notice must be provided in either January or June. And if, when doing a rescission, the issuer must provide an opportunity for an independent review. Issuers do have some flexibility to choose the applicable 6-month evaluation period for a notification of a rescission. But they must give the rescission notice within 2 months of the evaluation period. So that's kind of a constraint on, they can't just pick any 6-month period. It has to be within 2 months of the January or June notice timeframe. So here's an example of the timeline when an exemption is rescinded. So assuming that exemption was granted with notice in October, the rescission evaluation isn't really based on that October date of notice, but rather kind of the 6-month period applicable to the timing of the rescission notice. So for that rescission to be in place for at least 6 months after the grant of exemption, that first opportunity to rescind it is in June of 2023. In this example, the issuer has chosen an evaluation period running from October 2022 to March of 2023. The next evaluation period would follow when the first evaluation period ended, so starting April 1, 2023 to September 30th of 2023. And then that would provide a notice. So the soonest that an issuer or a provider could get their exemption back after it being rescinded in June of 2023 would be in December of 2023. Rescission notice requirements. The notice must include information about each healthcare service for which the exemption is being rescinded, the date that the notice is provided, and the effective date of the rescission, a plain language explanation of how the physician or provider can appeal and request an independent review, and an identification of the data that informed the rescission. So that includes the number of payable claims that were eligible for evaluation, the number of claims that were included in the random sample, and the result of each retrospective review, including detailed information for claims that didn't meet the issuer's screening criteria. So explaining why was this claim determined not to satisfy the screening criteria? Was it based on lack of records or based on an assessment of those records, similar to an adverse determination notice? The notice rescinding an exemption must also include space for the physician or provider to request an independent review, including the provider's contact information and the date the appeal is requested. It must also include space for the provider to request another random sample if available. Another random sample is available if at least 5 more claims were eligible for evaluation in addition to the original random sample. Finally, the notice must include instructions about returning the form before the rescission is effective. TDI has published Form LHL 011 as an example of a rescission notice, and issuers can use that notice or that form to provide rescission notices and independent review organization request forms. So it's an example that kind of illustrates all of the requirements that these notices must meet. And we try to make it a plain language example that issuers can borrow from, while at the same time giving issuers flexibility to make these forms work for them. So this is kind of a single form with 2 purposes, right? So it's both informing the provider of the rescission, and it's also can be used for that provider to turn around and send it back to request an IRO review of the rescission. So this is the top part of that form. It includes the date that the notice is provided. It includes the healthcare service subject to rescission and the effective date of that proposed rescission. Here's some kind of explanation of the purpose of the form, what the rescission means, and how the provider can request that IRO independent review. So we do want to make clear that the form should be returned to the issuer and not to TDI. Here's space for the issuer to provide their information and that contact instructions for the provider to send the form back to them. It also includes an explanation that the issuer sends the form to TDI, and then TDI then randomly assigns the case to an IRO, and that TDI will identify the IRO that has been assigned, and the IRO must make a determination within 30 days. So here's the part of the form that provides space for that sample information used to make the determination to rescind the exemption. Space for the number of claims eligible, the number of claims in the random sample, and a listing of those claims and whether they met the criteria. And then for each box that's checked no, the issuer must include that explanation, that kind of why did it not meet the screening criteria. And that can be provided in attachments. Obviously, the form itself doesn't include the amount of space you would need for that explanation. And then moving on, the form provides that IRO request. So if the provider wants to request an IRO review, and instead of just accepting the proposed rescission, they would then fill out this section. As well as indicating whether they want the IRO to review a separate random sample of claims if available. We do provide TDI's contact information if they need information about that independent review process. So again, issuers aren't required to use this form, but it's intended to be a resource to them to help them understand what those forms should include. Communication methods. The rules do require that issuers give physicians and providers the ability to designate a specific contact method and contact address for communications related to pre-authorization exemptions, denials, and rescissions. So they must allow a physician or provider also to submit appeal requests by mail, email, or another electronic method. So providers should be able to receive the communications in the manner of their preference, as well as submit appeal requests in the manner of their method. Issuers must also explain how providers can update their preferred contact information and provide that information on contact methods on the website maintained under 19.1718J. Again, that's the SB 1742 website that's required where all the pre-authorization requirements are published. And the information on updating contact methods should also be included on the communications under the rule. So when you're sending that initial notice of exemption or denial, that letter should include, hey, if you want to update your contact information, here's how you can do that. Moving on to appeal of rescissions. Physicians and providers can appeal an adverse determination regarding a pre-authorization to an independent review organization. Again, an adverse determination regarding a pre-authorization exemption is different from just an adverse determination, right? Because it doesn't lead to a denial of a claim, but rather it's a determination that one of those retrospectively reviewed claims was determined to not satisfy the screening criteria. And so, the requirements for these types of adverse determinations are different. Physicians and providers can request an independent review by submitting the rescission notice form before the rescission effective date. If a rescission is based on failure to provide medical records, the records must be submitted with the request for independent review. So this is an important point. We do hope and expect that providers will provide their medical records when requested to facilitate the retrospective review and the continued eligibility for their exemptions. But if they don't, the only way they can get an IRO review is by including those missing medical records with the request. So that's a really important requirement. So the additional random sample. So this is only available if there were at least 5 more claims that were eligible for review, but that weren't in the original random sample. So that means there had to have been at least 10 eligible claims submitted during the evaluation period. If the issuer only selected 5, of those claims in their original random sample, then the additional 5 can be reviewed. If there were only 8 eligible claims during that evaluation period, then there wouldn't be another random sample available for review. So to facilitate the ability of a provider to request an additional random sample, the issuer must provide a listing of all the payable claims that were eligible to be evaluated. So the time when they provide that is, so the provider sends their IRO request to the issuer. If the issuer sees that the provider requested another random sample and that an additional random sample was in fact available, then when they send the IRO request to TDI, that's when they would give that list of all the payable claims that were eligible to be evaluated. So the purpose of that list, they need to provide enough information that the IRO can use that list to randomly select an additional random sample. And then the IRO can ask providers or the issuer for the medical records. So the issuer might not have any medical records since those are claims that were not retrospectively reviewed. So any records that the health plan has, they should pass on to the IRO upon request promptly, and providers have only 3 days, since the IRO only has a 30-day review period. The provider must respond very promptly to the IRO request for medical records if they want the IRO to actually be able to evaluate those claims, and hope in the benefit of the provider. The IRO will review all the claims in the additional random sample and all the adverse determinations regarding a pre-authorization exemption from the original random sample. So say the original random sample had 5 claims and 2 of them were adverse determinations. And then the new random sample has another 5 claims. So the IRO would be reviewing 7 claims. And if both the first and the original random sample were sample sizes of 5, then the calculation of whether the rescission is upheld or overturned would be based on the approval rate out of a total sample size of 10. The independent review process. So the physician or provider sends the IRO request to the issuer. The date of the physician or provider request starts that 30-day clock, which is based on the statute. The issuer then submits the form to TDI. They have to do that within 1 business day. And then within 1 business day, TDI will randomly assign the request to an IRO. So that's all against that 30-day clock. Doesn't stop for the issuer submission and TDI's assignment. So the IRO doesn't actually have full 30 days to do their review. As mentioned earlier, if another random sample is requested, the IRO can ask for medical records from the provider, and those records must be sent within 3 business days. And again, the IRO must complete its review within 30 days of the date the provider made the request. The IRO must then communicate its determination to the issuer promptly, and the issuer has 5 days to communicate the IRO's determination back to the provider. Request for review by an IRO. Issuers will submit IRO requests to TDI for exemptions. They should use TDI's website and the online IRO request system. TDI will update its website to include pre-authorizations as a new type of IRO review. That's not ready now, but the first date that rescissions can occur is June 1st of 2023. So there is time for those updates to be made. The IRO request process really will be the same as our process for other IRO requests. So I know that hasn't been applicable for a few years for the ACA market since those IRO requests are now handled by the federal process, but TDI's had this system in effect for many years. For some issuers, it will be a new process. For some issuers, it'll be returning to that old IRO process before we transition to the federal process. Here's an example to walk through what it looks like when a rescission is appealed to an IRO. So that first rescission notice was issued, let's say, for example, in June 1st of 2023. It would then be effective July 1st of 2023. The provider may request an appeal at any time before that July 1st date. So let's say they wait till the last minute, submit their appeal request on June 30th. June 30th, that starts the 30-day clock for the IRO to complete its review. The IRO, after receiving it from the provider, sends the IRO request form to TDI within 1 business day. TDI receives that form and makes the random assignment of it to an IRO within 1 business day. Starting 30 days from the June 30th date that the provider requested the appeal, the IRO must complete its review. They must promptly send their determination to the issuer, and the issuer must send the decision to the provider within 5 days. So let's compare how the pre-authorization exemption review processes compares to your typical utilization review process. It's important to understand that an adverse determination regarding a pre-authorization exemption is similar to but different from an adverse determination for a traditional utilization review request. The determination is made by a Texas licensed physician, and it uses the same screening criteria about whether something is medically necessary or appropriate. But it's important to understand that when a pre-authorization exemption is in place, that type of adverse determination won't result in a claim denial. Instead, the result of the adverse determination regarding a pre-authorization exemption could lead to a rescission if it causes the evaluation to result in fewer than 90% of claims being determined to have met the screening criteria. So a retrospective review under the pre-authorization exemption statute is not subject to 4201.305 of the insurance code, because that is really more relevant for when a claim is being denied or a service is being denied. The IRO requests and the random assignments follow the same processes as other IRO reviews under 12.502 of the Texas Administrative Code. Also, IROs notify just the issuers of the determinations, and TAC 12.206 does not apply. So it's not relevant to notify, the consumer because a claim or service is not being denied. So the notice really follows the statute rather than the normal processes. So there's kind of a few exceptions from, the other rules related to utilization review and independent review, but otherwise most of the processes and standards are the same. And now we'd be happy to take any of your questions. I've provided a link to our website as well as my contact information.
All right, welcome back to the Q&A portion of our webinar. Let's have our panelists turn on their cameras. So joining us to field your questions is our presenter, Rachel Bowden. She's the director of the Regulatory Initiatives Office, and her team tracks life and health insurance policy issues. They oversee rulemaking and respond to legislation like gold carding. And joining Rachel is Robert Simons from TDI's General Counsel Division. Robert is the Assistant Director of the Office of Policy Development Counsel. So just a couple of ground rules before we get started. Any questions about a specific company, we're not going to answer in this forum. You can email those questions to us at lhlmgmt@tdi.texas.gov. I think we'll put that in the chat as well. And any questions that we don't get to during today's session, you can always email us at that same address, lhlmgmt@tdi.texas.gov, and we'll work on getting you a response. So first up, if a doctor believes that the reviewing physician on a peer-to-peer call is not the same or similar specialty, how can they complain about that?
Okay, yeah, we get a lot of questions about complaints, and that's definitely something we would like to see. I am about to send in the chat a link on how to file a complaint with TDI. So we do rely on complaints a lot for how we kind of monitor and regulate the market. So please file a complaint. On these type of health claim related ones, it's nice if the front of a patient's health insurance ID card is included, because then we can kind of get that information in the system that helps process that complaint. It's nice to use the online complaint system. After you answer the questions, you'll be asked if you want to upload supporting documents. So you'll have that opportunity to upload what documents you may be relevant, for example, the front of the patient's ID card, and that'll help the process go forward.
All right, very good. Here's the next question. If an ordering doctor already has the exemption in place, but they're working with a separate furnishing medical professional, would they have to provide an additional exemption, that furnishing professional?
No. So the ordering provider's exemption applies to that care that they ordered. So, traditionally, if that was the ordering physician's responsibility to get that pre-authorization, that responsibility wouldn't shift to the rendering provider. That exemption, that's where a treating provider's exemption is appropriately being used to, care that they aren't providing directly.
Okay, sounds good. We've had several asking about the date. There's not a lot of time to update our contact information. How will doctors be notified October 1st about the system?
Yeah, absolutely. So the health plans websites that are currently listing the pre-authorization requirements, those websites should have a method through which you can change and update your preferred contact information. And additionally, if you haven't updated your contact information, you'll receive that initial notice by October 1st. And on that notice will also include the information on how you can update, to say, oh, I want to receive these communications through, say, a dedicated email inbox.
Okay, so you can designate where to go. Next question, regarding the notices of exemptions or denials, will the notice include all services for which they're exempt? If so, how will the details be provided? Will we get descriptions, CPT codes, something else?
Sure. Yeah. So the notice will include each particular healthcare service that is subject to pre-authorization and explain, assuming that that's a service that the provider commonly provides, whether that provider has gotten an exemption or whether the exemption has been denied. So to be clear, a provider doesn't have to take any action to get an exemption. It's the health plan's responsibility to do the analysis and make those communications. There is, I think, as we discussed in the presentation, a minimum threshold of if you haven't filed at least 5 pre-authorization requests for that service in the last 6 months with that issuer, then that one is not subject to an exemption. So that minimum threshold, if it's not something you're commonly requesting, you're not going to get a notice. And I think also it's important to note that, this is applicable to TDI regulated commercial health plans. So that I'll say it's not workers' comp, it's not Medicaid CHIP, and it's also not those self-funded employer plans that make up the majority of the commercial market. So that TDI regulated market is maybe a quarter to a third of those commercial health plans that people get other than Medicare, Medicaid. So those self-funded plans don't have that TDI or DOI on the ID card, and they're not subject to the exemption.
Okay, perfect. Here's next question. Because insurance so often forces the primary cares to order everything, how does this count toward the ordering versus primary doc exemption?
Yeah, and I think Rachel probably covered that maybe
Okay.
just after this question was asked, but that's that treating, ordering discussion that Rachel had. And if you want to go back, I think it's on slide 6 of the presentation. And I think early on in the presentation, there's a nice link to that PDF, and it's on our website for the slides. So yeah, I think that's been answered.
Yeah, you're right, Bob. I think the questions started coming immediately, so I'm taking them in chronological order as much as I can. But yeah, some of these I know were answered as we went along. Is the exemption provider specific, or does it apply to all physicians within a practice? We talked about that too, right?
Yeah, the exemption is really tied to who is requesting the pre-authorization. That's the data that informs your exemption, and so that it applies at that level. You know, that might look a little bit different for different types of practices, but it really typically would be at the individual provider MPI number.
Okay, perfect. Does a partial approval or a partial prior authorization request qualify as an approval or an adverse determination?
Yeah, that's a good question. And as a matter of fact, basically the same kind of comment and question came in when we proposed the rules, because I think we originally had said full and final approval, and there was a lot of confusion about that. So we did modify it in the final rule adoption, where if you're those of you who like to look at the specific citations, it's in 28 TAC 19-17302, but we did change the verbiage. So it's not full and final. It is what do we say? The eligible pre-authorization request. So we did take that into account so that we understand that, in the pre-authorization process, sometimes there is a little back and forth and modification that has resulted, but ultimately a modified but approved prior authorization is not a denial.
Okay. Next question up here. Is there a requirement for the method of exemption notification to the provider, and how often that's going to happen, the frequency of the notification?
Yeah, so I think going back to the presentation, in terms of the timing, it's complicated just because, you know, depending on your status of exempt or non-exempt or rescinded, the timing varies. So I think the flow charts in the presentation are a better guide to the timing question than I could provide in words. With respect to the form and method, I mean, I think as we discussed, providers have the opportunity to request their preferred method of communication. So, you know, it could be by mail. The first one might come through kind of the normal method that you're receiving communications from that health plan. And if you have a different preference, then you can choose that.
Something related about the communication. Is there a web portal where providers can go to see or check their score?
So there will not be a TDI web portal. So no centralized portal for all insurers now.
Okay. So just work with the plan that you're working with. Next question up here. Is it appropriate for an office's NPI or solely the independent rendering provider? Again, this is an individual versus the whole group, right?
Yeah, I think we covered that one.
Okay. Let's go on to the next one here. Do registered nurse practitioners need their own exemption if they're working under a doctor already?
Right. If you are practicing under a doctor, it would be appropriate to use the doctor's MPI number. If you're practicing independently and making pre-authorization requests under your own MPI number, then then you would need your own exemption.
Okay. Are hospitals considered treating providers?
I think they definitely could be in some circumstances. I think, you know, it does get more complicated, but I think the general rule is the level at which pre-authorization requests are being made. That's going to be the source of the data to, you know, to determine who qualifies for an exemption.
Okay. Do you have to be in the plan's network to qualify for an exemption?
No, the statute doesn't limit the scope of the exemption to in-network. I think it would be less common just in terms of like the volume of pre-authorization requests that you'd be doing with respect to a particular plan. But it's possible that an out-of-network provider could get an exemption.
Okay. Next question. Can you please explain how this is going to apply to third-party administrators who only provides medical necessity review for level of care and service appropriateness?
You know, generally, these requirements are going to apply to the health plan issuer, and you know they will provide guidance to TPAs that are involved in their care. You know, I think certainly a TPA that is doing pre-authorization will, you know, on behalf of a TDI regulated health plan, will need to, you know, follow the exemption requirements.
Okay, very good. Next question. So does each individual CPT code performed by the doctor have to be individually approved or denied based on that 6 months of data?
Yeah, so when we talk about the definition of a particular healthcare service being tied back to the issuer's website that lists out all the pre-authorization requirements, that listing is really what defines a particular service that's eligible for an exemption. I think we saw several questions about this on like drugs and like the level of granularity, and that could vary plan to plan based on just how an issuer designs their pre-authorization requirements. So some might have a different requirement for a 10 milligrams versus 50 milligrams, and others might just list it at the drug level. So, you know, TDI felt like we definitely weren't qualified to get into that level of granularity because it I think is appropriate for it to vary service to service. How granular does it need to be? Does it need to incorporate the diagnosis as well as the CPT code, or you know the unit numbers? And so it really ties back to the way the pre-authorization requirements are listed and designed.
Okay, thanks, Rachel. So this one kind of reverses one of the questions we had earlier. What happens if the providing or rendering provider has an exemption and is the one that's requesting pre-authorization at that point, but the ordering provider did not have an exemption? Does the exemption attach to the provider who ordered as well as the requesting pre-auth?
I think that one's a little bit complicated. I think it would be fairly unusual. I think theoretically an exemption could apply, but it might get complicated just based on where the health plan actually places the responsibility for pre-authorization. Some of those things are built into contracts, so I don't want to get too specific for things that could vary health plan to health plan.
Okay, so those are the things they would have to email us to get into the specifics of a question like that. All right, so here's the next question. Please confirm my understanding. If Dr. A orders an MRI at an imaging center, and it's been determined that every prior auth where Dr. A is the ordering physician is approved and has that 90% goal, does Dr. A no longer need to submit prior authorizations at all for the care he's rendering?
They don't need to submit pre-authorizations for the care for which they have received a pre-authorization exemption with respect to a particular health plan. So for a particular MRI CPT code, maybe you've gotten an exemption from one health plan, but maybe not for another, or maybe for one MRI CPT code, but not for another MRI CPT code. So, you know, there is a lot of specificity involved.
Okay. If you have a plan that has both TDI, HMO, and PPO and Medicaid products, is the prior authorization evaluation done across all lines of business, or you just pull the PAs from the TDI products?
I think in our adoption, we referenced that we would encourage health plans to use the data. If they have a common set of pre-authorization requirements, it might be appropriate to include data from self-funded plans or from Medicaid plans, to better inform their analysis, and that wouldn't be inappropriate. They're not required to extend the exemption beyond TDI plans or necessarily required to look more broadly, because there might be a different set of pre-auth screening criteria for Medicaid, for example.
Okay. What insurance networks does this apply to? Is it all commercial plans? And if we're not received any notification, how do we see if any physician is approved or denied for a specific CPT?
I think in terms of networks, I think we talked about it. It's TDI regulated plans. If the notifications are due by October 1, technically, that might roll to the next business day. So I would say after October 3rd, if you haven't received a notice, it would make, and you really think like this is, your data, you qualify, I would encourage you to reach out to the health plan. I think most of the health plans are working in good faith to get this implemented promptly. And hopefully they can give you an explanation. And if you're not satisfied with what you hear from your health plan, please do reach out and complain to TDI. As Bob said earlier, complaints really help us know what's going on in the market. And that is how, the kind of the front line for monitoring compliance, understanding where there's issues, and working with health plans to get those issues resolved and get them into compliance with these rules.
This is another one about the practice. Can a physician with an exemption refer a patient to another doctor in their practice who does not have an exemption for actual performance of the procedure?
That sounds a little bit like trying to game the system. Obviously there can be a lot of different circumstances, but the concept of like, when are you actually a patient's treating provider? It sounds unusual to me that if me and my partner both, are surgeons and do the same care, but I have an exemption and they don't, that I would be their treating provider just for the sake of ordering care that's going to be rendered by my partner. So, these things are somewhat case by case, but I think people understand the intended scope of when it's appropriate.
The spirit of it. We're almost out of time here. Let's try one more. If the physician does not have 5 claims during a review period, does that mean they'll be evaluated during the next review period?
Yes. So every review period is a new opportunity. Every review period looks at the applicable 6-month evaluation period. There's a new opportunity every 6 months to potentially qualify.
Sounds good. Well, we are at our time right now. We're gonna have to wrap it up here. It's 3 o'clock. If we didn't get to your question, or you think of something else that you need addressed later, please go ahead and send them to that email, lhlmgmt@tdi.texas.gov, and we'll get back to you with an answer if we can. That's it for today. Thanks for joining us. Have a great rest of your day, and we'll see you at the next TDI webinar.